Talking about blood vessels, right? So first, capillaries, right? Even though they're rather small, there are different types of capillaries, and that actually makes a lot of sense if you look at the function. So three types of capillaries are continuous capillaries, fenestrated, and sinusoid. And the major difference, the most principal difference between them, is their permeability. Everybody understands the word permeability because I'm going to be using it a lot. Permeability is how easy it is for cells and chemicals to go across the wall of the capillary. Good? So continuous capillaries are least permeable. They provide pretty good separation of the blood and the tissue. It can be found in the structures like a brain, where you don't want a lot of exchange between the blood and the tissue, blood and the brain, except for respiratory gases and basic wastes. You don't want cells to go back and forth because that may also bring pathogens. Does that make sense? So this skin, muscles, and brain. Okay? Cells, the endothelial cells in such capillaries are connected to each other by so-called tight junctions. Okay? There are small intercellular clefts, which are pretty much like a crack in the wall. They're small enough to let passage of fluid, plasma pretty much, not even plasma, water and small molecules, but not big enough to let large molecules like proteins to cross the wall of the capillary. Does that make sense? So that's why, if you think about this, blood-brain barrier protects the brain really well from any type of infections. Okay, systemic infection that would affect muscles is very rare. Same goes for skin. Infections of skin and muscle usually come from the outside. You injure the skin, right? You make a cut, any kind of wound, then skin and muscles become infected. But from the blood, it almost never happens. Because of the good separation of blood and tissue by the continuous capillaries. Second type is fenestrated. As you can tell from the name, these endothelial cells in these capillaries have fenestrations, opening. Do you know the word somebody was fenestrated? No? When somebody is fenestrated, it means the person was thrown out of the window, which is an opening. No, seriously, it's like fenestration is throwing somebody out of the window. Okay? In this case, fenestration refers to the opening, like a window in an endothelial cell. So that allows more exchange between the tissue and the blood. You're going to find this, obviously, in the locations where that exchange is critical, like endocrine glands, right? Where hormones have to go back and forth. The kidneys, where plasma filters into the glomerular capsule, for example. Does that make sense? The most permeable are sinusoid capillaries. You see that fenestrations are gigantic, okay? Tight junctions, although they are still present, they aren't as abundant as in continuous capillaries. And there's also, you can't really see, there's adenocytosis, which means there are vesicles in endothelial cells that will shuffle stuff between the blood and the tissue and back. Does that make sense? Okay. So these guys are very permeable, and they will be found in the organs where not only exchange of fluids, but also exchange of cells and other large aggregations occur, like liver, or spleen, or bone marrow. And it explains a lot of infectious stuff, actually, if you think about it. Good? No, look at liver.
Is it like a filter almost?
it's not a filter, but it, say, spleen takes care of the old red blood cells. Okay, so red blood cells can move through the wall of the capillary in the spleen and be devoured by splenocytes. Okay, liver is responsible for many things, among them metabolism of fats, right? So it packages fats into the low density lipoproteins, which are pretty big. That's why you need sinusoids. Those particles go into the sinusoids, okay? Or chylomicrons, to take chylomicrons from the blood into the liver cells. Chylomicrons are big. So when you have a large particles exchanged between the blood and the surrounding tissue, you're going to have sinusoid capillaries. And you can guess fairly easily that those sinusoid capillaries provide actually a decent entry for pathogens. If you would actually look at many systemic infections, a lot of them may cause hepatitis, a lot of them may cause infection of the spleen, and many of them end up in the bone marrow. Okay? That's where they can go easy, right? Now, to avoid or to prevent this, at least partially, macrophages, cells that protect against this, they can be found in the walls, the epithelial lining of the capillaries. Does that make sense? Now, capillaries form so-called capillary beds in the organs. Networks, you see them here in this illustration. The arteries, okay, they become smaller and smaller until they reach the smallest size, which is still going to be in the arteriole, so-called terminal arteriole, okay? And the terminal arteriole delivers the blood into the capillary bed. You follow me so far? So blood flows through the capillaries in the bed, and there's an exchange between the blood and the surrounding tissue. Depending on the organ, capillary beds are going to be different. We just discussed that sinusoids in the liver are very much different from continuous capillaries in the muscle, right? So those beds will have different properties. Is that clear? That capillary beds in different organs are going to be different, okay? Now, the part of circulation that is pretty much the smallest vessels, like these terminal arterioles, that lead to capillaries, they are called microcirculation, microvessels. Vessels with a diameter less than 100 micrometers. That includes little arterioles and little venules. To give you an appreciation of that, you see those three glass boxes in that corner next to Joe with the circulatory system? You see how many vessels there? Has anyone been to the exhibition, something like a body something? Huh? Like plastified human bodies. If you have a chance, go. It's not creepy, really. It's pretty interesting. So what they do, they take a corpse and fill it with a special solution that plastifies the corpse, and they can shape it in a certain way. They can pretty much do this in the way that all blood vessels are preserved and all other tissue is gone and stuff like that. So they can put the person in a bicycle and you can see which muscles are working, how ligaments are stretched and stuff like that. It's really interesting. And those people donated bodies to the science, so there's nothing illegal about it. And it's a great technique. It gives you the cadaver that doesn't stink. It's like plastic with all miniature structures preserved. So if you would go to such an exhibition, there will be probably one of the things there will be the circulatory system. So it's pretty much all blood vessels, all of them. And that's it. All other tissue is gone. Only blood vessels. And if you would look at this, it's like a person. Blood vessels, they have a shape of a person. It's fascinating. Most of those blood vessels are those really tiny, small microvessels. It's 95% of all vessels, surface-wise. To give you an estimation of a surface, microvessels have a surface, inside surface, of a football field. There's a lot of exchange going on. That's why the studies of microvessels are so important. The first signs of cardiovascular disease appear in the microvessels. So even the person may not show any signs of atherosclerosis or endothelial dysfunction in the large vessels. But in the small ones, signs are already going to be obvious. Does that make sense? Okay. So the route of the blood, when it flows through the capillary bed, goes from the terminal arteriole right here into the med arteriole, and from the med arteriole goes through the capillaries. Okay? The blood flow through the capillaries is regulated by structures at the beginning of each capillary that is called a capillary sphincter. You see sphincters right here. So when sphincter closes, it blocks flow through the specific capillary. Does that make sense? So that's how the blood flow through local tissue is regulated. Does it make sense? Locally. It's very local regulation. It's not systemic. It's local regulation. Huh? Exactly. Exactly. Say when tissue becomes hypoxic, sphincters will dilate to increase the blood flow. When when tissue becomes like hyperoxic, they will constrict to decrease the blood flow. Does that make sense? From the capillaries, blood goes into the postcapillary venule, and then it is collected by bigger vessels. You probably noticed that I didn't mention thoroughfare channel. It's the direct communication from the terminal arteriole to the postcapillary venule. So if all sphincters are closed, blood still can go from the artery to the vein. Does that make sense? Otherwise, we would be like royally screwed. Okay? So this vessel here is called a thoroughfare channel. It represents a type of the vascular shunt, or another word for it, anastomose. Now, it may sound like a complete Greek thing, anastomose, not English at all, which is probably actually is a Greek word, anastomose. Anastomosis can be arterial. In coronary circulation, we have a lot of anastomosis. They can be venular. If you would look at your veins, I mean, if I would be able to pump them right now, okay? If you would look at your veins, you would see anastomosis in your veins. Like I have one here between two veins, superficial veins. Just a short fragment here that connects to other veins. That's anastomosis. Okay? And they can be arteriovenular. So vascular shunt is an example of arteriovenular anastomosis. You're good with that, I hope. That makes, no, I mean, just, it's a lot of new terms, but structurally it makes a lot of sense. Okay? So blood flow, as David already inquired, so blood flow is regulated by chemical cues, mostly carbon dioxide actually, not so much oxygen, carbon dioxide, hormones, right? Epinephrine will close acetylcholine will open, depends on the tissue, and nerves, right? For instance, sympathetic stimulation will decrease the blood flow through the intestines, but will increase blood flow through the muscles. Does that make sense? Awesome. I know that's the favorite part of all the students because it involves math and physics, your favorite subjects. Next, we're going to talk about blood flow. Really, we're still talking about plumbing. Okay. So, what I want to talk to you in the last 20-something minutes of the class, I don't know how far we will go, but what regulates blood pressure? Okay. To give you a clinical perspective, what is the percentage of deaths in the United States that is caused by different types of heart disease, heart and vessel, excluding stroke? Any wild guesses? No. What I'm saying is all cardiovascular diseases except stroke. What percentage of people, like we have, I don't know, 400,000 people die in the US. Which percentage of those die because of the cardiovascular disease? No, too much. We have cancer, don't forget. 20%. 20% of all deaths directly, like myocardial infarction, okay, aortic aneurysms and stuff like that. Direct cause is cardiovascular disease. 5% is stroke. So if we take them together, it's 25. How many diseases are aggravated by poor cardiovascular health? We don't know. Does it make sense? So you can safely say a quarter of deaths in the US is due to the cardiovascular disease. It's a lot. Okay, so and most of it, like, okay, atherosclerosis and high blood pressure. Two things that kill people. Okay, where they come from is the separate story, but so we need to figure out how blood pressure is regulated. For this, we have to define a few terms. First, the blood flow. Second, pressure. Third, resistance. Flow, blood flow, through the organ or through the tissue is the volume of blood that goes through the organ or tissue in a minute. So systemic blood flow through all the tissues is, can you give me a synonym for it? It's cardiac output. Yes. Does that make sense? That's amount of blood that heart in a minute is cardiac output, which is equivalent to systemic blood flow through all organs and tissues. Okay? But although it is equivalent, it will vary between the organs. Blood flow through the kidneys will be 25% of the entire systemic blood flow. Blood flow through the brain at rest, 15%. Okay? Okay, is that clear? Blood pressure. Force that blood exerts on the unit, 1 unit of the vessel wall area. In the simple terms, how strong it pushes on the walls. That's it. Okay? Measured in millimeters of mercury. If you don't mind, when I will refer to blood pressure, I'm just going to say numbers. It's always going to be millimeters of mercury, okay? So when I say 120 by 80, millimeters of mercury implied. We're good? Now, blood pressure is a systemic parameter. Ideally, we should measure blood pressure at the place where aorta leaves left ventricle. We cannot do that without killing a patient, so it's going to be an invasive procedure. So we should measure it in the large arteries, okay, like axillary or brachial artery. That's what we do. I always propose another way of measuring blood pressure on the carotid artery, putting the cuff on the neck, but I think by the end of the measurement the patient will be dead, well, partially suffocated at least. We should measure the blood pressure as close to the heart as possible. Okay? Now, pressure is highest at the heart, where blood leaves left ventricle. And then it declines. It gets lower and lower as the blood gets to tissues, and then it gets slower in veins, and essentially at the right atrium it's 0. Does it make sense? So blood flows following to the pressure gradient from left ventricle to right atrium, from high pressure to low. Does that make sense? Excellent. Resistance, the force that blood encounters when it flows through the vessels. Opposition to flow. That makes sense? So, think about this. You have a pump that generates blood pressure. And you have pipes that are resistant to the flow. So if you have a very strong pump, then even small pipes will still produce good flow. If you have weak pump, then even large pipes will not give you a good flow. What I'm trying to say is that blood flow, it makes perfect sense. Blood flow is directly proportional to the pressure and inversely proportional to the resistance. Does that make sense? Okay? So blood flow is equal to the cardiac output, systemic blood flow. You agree? We just discussed it, right? So cardiac output is proportional to the blood pressure and inversely proportional to peripheral resistance. Now, if we want to find blood pressure, so blood pressure will be proportional to both cardiac output and peripheral resistance. Now, going back from the terms to the logic, when we say increased cardiac output, what do we mean? How can we increase cardiac output? How can we increase cardiac output? I mean, in terms of the parameter of the heart. So when you exercise, what happens to your heart rate? So can you increase stroke volume, the amount of blood that is pumped with each contraction, or so you can increase either the heart rate or the pumping capacity. If you think about it, it makes perfect sense that increased heart rate, for example, will increase blood pressure. Does that make sense? Resistance, again, try to drink through the steerer. I had a chance to visit the John McGovern Health Museum in Houston, Texas. And they have a wonderful demonstration. They have an example of the resistance, pumping resistance, on different stages of atherosclerosis. Bless you. So first, you try to pump a fluid through the pipe, and it kind of says, okay, that's normal. And it was easy, really. I mean, my kids could do that. I could do that easily. And then, skipping the intermediate stage, they say, that's the severe atherosclerosis. Same diameter of pipe with like pull-ups inside. Kids could do pull-ups, on the handle. They weight wasn't enough. I really had to apply a lot of force to just pump fluid through this. So decreased lumen of the vessel increases resistance significantly. Does that make sense? When you have to pump through this smaller hole, it's harder. Does that make sense? Okay? So let's figure out what actually affects the resistance. Viscosity of the blood, how dense it is. Okay? What will increase the blood viscosity? Things like if you have more red blood cells. If you decide to shoot yourself with erythropoietin, the hormone that stimulates production of red blood cells. If you decide that you're a second Lance Armstrong, it increases the risk of stroke actually quite significantly. Okay? Have thicker blood? Yes. Yes. Like you can get dehydrated and increase viscosity. But you have to be like really dehydrated. Not that, oh, I didn't drink a cup of water in 3 hours, I'm dehydrated. No, that's not something that's going to change it that much, okay? But when you're dehydrated, increased viscosity is the huge risk factor. Length of the vessels. If the heart has to pump blood through the longer vessels, it has to develop higher pressure, so increased body size. And that may contribute to the increased blood pressure in obesity. Okay. Turbulence of the flow. If you go to the really calm river, all water goes without any whirlpools or anything like that. Does that make sense? I'm not really strong with the English words regarding the river flow. Like how you call these things? The ripples, waves. Yeah, there are not so many of those. But if you go like the Chagrin River, that is pretty fast, especially after the rain. All different kinds of things like that. Okay. So when the flow meets a boulder or a log, the water starts to ripple around it. Does that make sense? And that actually increases the resistance to the flow. So what can do this in the blood vessel? Plaque. Yes. Bless you. And actually any kind of branching of the vessels. Branches, the point of branching, is intrinsically prone to atherosclerotic plaque formation. When doctors look for the plaques, they look at the branch points. That's where they are first. Okay? But most important factor is vessel diameter. Peripheral resistance is inversely proportional to the vessel diameter in the power of 4. Translating into the language of normal people, if you decrease the diameter of the vessel 2 times, what's going to happen to the resistance? Will it go up or down? Up. How much? Power of 4. 16 times. Vessel constricts twofold. Resistance increases 16 times. It's just a law. It's just what happens. 2 in the power of 4. Vessel dilates 2 times. Resistance drops 16 times. Does that make sense? It's pretty neat. So, how blood, that's going to be the last thing for today. Blood, when it is pumped through the systemic circuit. Where's my water? So blood flow essentially is generated by the heart. Okay? And vessels, when they provide resistance, this is what generates pressure. Because think about this. If there would be no resistance, there would be no pressure. Just think about it for a second. No resistance, no pressure. Okay? So highest pressure will be observed in the aorta, and then it starts to decline. The steepest drop of the pressure happens in the arterioles. So arterioles are often called resistance vessels. And regulatory mechanisms that actually alter the blood pressure in the system, they mostly work in the arterioles. So these are the critical regulatory points. Okay? Pressure in the arteries depends mostly on the elasticity of the large vessels. Does that make sense? So when blood is pushed from the left ventricle into the aorta, its elastic walls stretch. And during the systole, the ventricular systole, aorta stretches. During the ventricular diastole, it recoils back. Okay? So essentially, blood pressure is not constant, so it goes up and down. Okay? And then in the arterioles, closer to the terminal arterioles, closer to the capillaries, it's not pulsatile anymore. All these pulsations are buffered. Okay? Normal systolic pressure is 120, diastolic is 70 to 80. We're going to talk about hypertension, and these numbers that I give you is a medical consensus that is shattering now. That this is normal, this is being questioned. Now, pulse pressure is the difference between the systolic and diastolic. Essentially, that's the pulse. When you measure the pulse, you measure that, you feel that difference. If we will try to take the pulse, hypothetically, at the small arteriole, you won't be able to. There's no pulsation. Flow is not pulsatile. That makes sense? Now, mean arterial pressure is calculated as the diastolic pressure plus 1/3 of the pulse pressure. So say we have a patient with 119/80. So what is the diastolic pressure? 80, yes. What is the pulse pressure? The difference between systolic and diastolic? 39. What's 1/3 of 39? 13. So systemic blood pressure will be 80 plus 13, 93. Does that make sense? Just the way it is calculated in the clinic. So if you have a patient, you need to report the blood pressure. Instead of reporting 2 numbers, you report 1. That's it. Does that make sense? So at the moment the blood goes to the capillaries, when it leaves arterioles and goes into the capillaries, pressure is 35. When blood leaves capillaries, it's about 17. Okay? So it drops. Lower pressure is always better. Some capillaries have higher pressure, like capillaries in glomerulus, in kidneys. Glomerular capillaries have high pressure. Okay. Now, walls of the capillaries are very thin, right? Endothelium and basal lamina. So if pressure is high, fluid will seep through the walls and people will develop edema. So that's the risk of high blood pressure in the capillaries. And resistance vessels, arterioles, right here, they will regulate the pressure in the capillaries. Does that make sense? Good. Venous pressure is pretty much constant. It's slow, but interesting enough, veins. Now look at the veins. Most of the blood is lower here, right? Legs, abdomen, and for some reason this blood at this low pressure, 15 millimeters, it still can go up against the gravity. So what helps it to go up? Several mechanisms. Muscular pump. When muscles contract, they squeeze the veins and milk them up. Second, respiratory pump. Look, I'm going to inhale. My chest expands, that's where my heart is. My abdomen squeezes. So it puts pressure on the abdominal veins and lowers pressure in the thorax. So blood rushes up. Does that make sense? A little bit of contraction, just a tad. But one important structure in the vein is the venular valve. Valves, they look like semi-lunar valves. They prevent backflow. So blood goes up towards the heart, and if there is any intention of the blood to go back, valves prevent it from doing that. Does that make sense? Goes up, but not back. Up, forward, but not back. Does that make sense? Okay. So we're going to talk about regulation of blood pressure next time.